Hello, everyone. This is a lecture for ANP3, week 9. Should the internet go out, this is an asynchronous recording of the lecture. It will be abbreviated compared to what we usually do with all the fun questions. Please do save your questions and email, text, or ask them next time. So we're going to dive in with our set of slides here to the best of our ability. So we're going to start off with the slides specific to this week, neuromuscular connections. The images that follow are specific to the types of neurons. We can see our neuromuscular connections between a dendrite, information bringing in, axon going to the neuromuscular junctions at the muscle fibers. And we're going to dive in with that in a little bit later. But for right now, we're going to start with innervations. As you can see here, we've got an image of the brachial plexus. Brachial plexus being really where we're going to start off with today. We're going to look at the innervations coming from the brachial plexus. But before we begin, a couple of quick rules about muscles, which will be important later. Remember that muscles will only pull, they never push. Muscles never push, they only pull. This becomes important when you think, okay, well, I've got a muscle that pulls my arm in one direction. You have to have an antagonist muscle that pulls it in the other direction. That becomes important when we talk about reflexes at the end of this lecture. Number 2, in order to move a joint, a muscle must cross that joint. If the tendons of a muscle do not cross the joint in question, it does not move that joint. Important rules to follow, and we'll talk more about those as the weeks come on. We'll start with the brachial plexus. The brachial plexus is a cross bridge of nerves emanating from the spinal outlets of C5 through T1. Their function is the innervation of the shoulder girdle to the ends of the upper extremities. So lots of different nerves here, lots of different nerves. Here are the nerves that you should be aware of and be able to identify. It seems like a lot, and each one innervates 1, 2, 3, sometimes more muscles. So let's go down this list and learn which muscles are in play. First off, we have the axillary nerve, which is behind the axillary artery in front of subscapularis. The axillary nerve is responsible for innervating deltoid and teres minor. Feel free to palpate deltoid. We all know where deltoid is. And reach under the arm and palpate about where teres minor would be from the lateral border of the scapula. Those two muscles are specifically innervated by the same nerve, the axillary nerve. Damage to that nerve might mean that your shoulders are rolled slightly forward, and you have difficulty abducting your arms. Very good. We also have a suprascapular nerve. Suprascapular nerve is going to emanate toward the top of our scapula, and it will innervate both our supraspinatus and infraspinatus muscles, both. So if you can palpate supraspinatus and infraspinatus, they're right close together. They're going to be innervated by the same nerve, the suprascapular nerve. I strongly advise getting out your copy of Trail Guide to the Body and looking these up and following along. Feel free to pause this lecture and come in and back as you check out each one of these. It should facilitate this learning much better. We have an upper subscapular nerve, which will innervate subscapularis. But if we've got an upper, that means we also have a lower subscapular nerve, also innervating subscapularis. Both the upper and lower subscapular nerve will go to subscapularis. 2 nerves for that muscle. Must be something important with subscapularis. The lower subscapular nerve will also innervate teres major, again, along the lateral border of our scapula. We also have a medial pectoral nerve, which means we're going to have a lateral pectoral nerve. Medial pectoral nerve is going to innervate pectoralis major and pectoralis minor. Pectoralis major and pectoralis minor have very little in common. They are shaped differently. They're different types of muscles. They move different joints. They have very little in common except for this nerve. I think about some of you may have a sibling where you have absolutely nothing in common, different politics, different jobs, different ways of looking at the world, but you have the same parents. It's an example akin to that. Medial pectoral nerve will innervate pectoralis major and pectoralis minor. The lateral pectoral nerve will innervate just pec major. So again, pectoralis major gets two nerves unto itself. Very good. Very good. One that I love to ask, and New York State loves to ask, is the musculocutaneous nerve. Musculocutaneous nerve rises from C5 through C7. It innervates three important muscles: biceps brachii, brachialis, and coracobrachialis. All three of those will be innervated by the musculocutaneous nerve. And believe me, I'm going to ask about it on a quiz and probably your final exam. And you will probably see this on the New York State boards as well. Musculocutaneous nerve. You can think of it as the anterior compartment of the upper arm or the proximal arm. We also have the long thoracic nerve. It used to be called the respiratory nerve of Bell. It doesn't do a whole lot of respiration. It will help with rib movement, but when you know what it does, it travels down underneath and is going to specifically innervate the serratus anterior muscle, this muscle on your flank, underneath your arm. It's more for protraction of the shoulder girdle, but it does help a little bit with respiration. But long thoracic nerve, serratus anterior muscle. We also have a dorsal scapular nerve. This is a scapular nerve closer to the back or the center of the back, the dorsal surface. This is going to innervate our more back-located scapular movers like rhomboids, major and minor, as well as the levator scapula muscles. They're all with the dorsal scapular nerve. Thoracodorsal nerve. This nerve is the one that has to travel the furthest. It's going all the way down to the belly of latissimus dorsi to innervate. Remember, latissimus dorsi is located in your lower back, but it moves your shoulder. Please keep that in mind. It may be located in your lower back, but it has big, long extensions of its body and feelers all the way up, and its tendons insert into the intertubercular groove, which means it is going to move your shoulder. Next one is really easy. By contrast, the subclavian nerve is going to move subclavius. Ta-da! That's it. Subclavius draws your clavicle down in motion. And then we get to our three forearm, lower arm, distal arm nerves. And those are radial, median, and ulnar. I'm going to give you the easy way to remember what's innervated with these. We'll start with the radial nerve. The radial nerve is going to innervate everything on the posterior arm, from the triceps all the way down to your fingertips. Anything existing on the posterior arm is innervated by the radial nerve. That's really straightforward, isn't it? That's all radial nerve. Median nerve, we look to the anterior lower arm, and the median nerve is going to accomplish most of the other muscles of this area. Most of the other muscles, and really stop just short of the hand itself. Most of the anterior arm compartment, lower arm compartment, is going to be the median nerve. The exceptions there are going to be the ulnar nerve. Ulnar nerve is going to innervate flexor carpi ulnaris and flexor digitorum profundis, just half of it. It's more responsible for the lateral portion of the arm, it being the ulnar nerve. If you have damage to the ulnar nerve, it might develop into this structure called claw hand, where your fourth and fifth digits are flexed and the others are out. Right. The other tissues it mentions are structures that are attached to the flexor retinaculum, potentially. Muscles that are moving the thumb and digiti minimi, which is your little finger. So yeah, a lot of stuff there, How much do you need to know? I'm definitely asking musculocutaneous. Technically, you need to know all of them for future testing. But if you are careful with your studying, you should be aware of most of that material. Okay. From this point, we start talking about reflexes. And to assist with the look of reflexes, we're going to go to a different set of slides for that particular discussion. We're going to look a little bit of spinal cord physiology related to the issue of reflexes. We all remember that white matter tracks conduct nerve impulses to and from the brain, and gray matter receives and integrates incoming messages. When that comes to the spinal cord, the gray matter is going to perform spinal reflexes. Reflexes are autonomic functions where our muscles will contract to prevent damage and maintain homeostasis. We can see some ascending tracts and descending tracts here on the spinal column. Reflexes are fast, involuntary, unplanned responses to a particular stimulus. Fast, involuntary, unplanned. They help maintain homeostasis, and the gray matter of our spinal cord is the thing that does the response of a reflex. Reflexes go through the spine. Here we see a standard reflex arc. The signal comes in this case, looks like a nail in a piece of tissue. That signal will be sent by sensory neuron up to the spine. The integrating center, or the H, the butterfly in the middle of our spinal cord, will integrate and send a motor response back following the motor neuron, and it will engage effector muscles to pull away from the stimulus. That is a normal reflex arc pattern. Little vocabulary: ipsilateral, that's when a reflex is on the same side. Contralateral is when a reflex occurs to muscles, it engages muscles on the opposite side of the body. Monosynaptic, monosynaptics are when one nerve signal goes to one neuron and that second neuron sends the response, one nerve to one nerve. Polysynaptic means that multiple neurons are involved within the response. Reciprocal innervation is the idea that when an antagonist muscle fires, the agonist will release. We're going to do a whole exercise on that for homework about reciprocal innervation. First reflex to discuss is the stretch reflex. Many of you have been to a doctor before. You've been hitting the knee by a little hammer. You can see the little hammer there. What happens is when the tendon is compressed, your body will actually engage the muscle of the tendon that was struck in order to prevent that tendon from being damaged. That is called a stretch reflex. Muscle is engaging to prevent that reaction. We also have a tendon reflex, sometimes called the inverse stretch reflex. When you push back on the leg, the muscles again you're going to engage the antagonist muscle to prevent that structure from actually tearing again. You'll actually engage the antagonist, which will release that tendon. We do this a lot with organized stretching, with resisted stretching, things like PNF or MET as massage therapists. We get our clients to resist the stretch before we take the stretch a bit further. That's what this is. It is an inverse stretch reflex. It's meant to release tendons when extending mobility. We also have the withdrawal reflex. For those of you who have ever stepped on a Lego, here's a great one for you. This is going to withdraw a limb to avoid injury or pain. It happens when you touch a hot pan and you jerk your hand away. That is a withdrawal reflex. It is your spinal column specifically trying to avoid localized damage, and it will occur before you feel the pain. You will start withdrawing your tissue before you feel pain, thanks to these withdrawal reflexes in your spinal column. Good. Along with that one is potentially the crossed extensor reflex. When it's your foot, specifically when you've stepped on something and you withdraw your foot, your weight will instantly shift to your other leg. We'll say that again. When you pull up one foot because you've stepped on a knife, a Lego, jacks, any number of different things, the other leg will extend in order to catch your weight so you don't fall down. That is a crossed extensor reflex. If you'll look through these, stress reflex, we mentioned monosynaptic. We can see how this one can be monosynaptic, but all of the others usually involve multiple synapses, multiple nerves in play in order to make them happen. Certainly when you have to instruct muscles on the opposite side of the body to do it. Very good. A couple of disorders to go with that. Sometimes people become paralyzed. Excuse me, due to various reasons. If it is a spinal cord injury, if it occurs below the level of T1, you might be dealing with paraplegia. Paraplegia is where two limbs are paralyzed and it's always the legs. If it's paraplegia, it's always the legs because it's damage to the spinal cord. Damage to the spinal cord leads to a spastic paralysis. Folks with spinal cord damage you'll sometimes see the muscles contract and then release. That is a spastic paralysis, and we see that with paraplegia, which is just the legs, or quadriplegia, which is the arms and legs. That occurs when damage occurs to the cervical plexus at the level of anywhere from C5 to T1. You won't survive if you break too much higher than C5, as we've discussed, but that is worth mentioning that it does lead to quadriplegia. The other two that are listed here, hemiplegia, is where just one side of the body is paralyzed. That usually results from brain damage associated with a stroke. So hemiplegia, we see that with a stroke. Whereas monoplegia is damage specifically to the peripheral nerves themselves, sometimes at the area of the plexus that's involved. One limb is involved, and because it's the plexus, not the spinal cord that's involved, if the nerve is completely severed, you get what's called flaccid paralysis. That's where there's no engagement of the muscle whatsoever because there's no messages getting to and from the muscle. Very good. Very good. So getting back to our original set of slides here, just to take you through that one more time. Reflex arc is the subconscious motor response to a particular stimulus. We see the hammer. We saw that with various other demonstrations. We see this slide here again. Stretch reflex, stretched muscle will engage due to pressure put upon it. The tendon reflex will engage a stretched muscle to prevent damage. Flexor reflex, retraction reflex from a negative stimulus. And a crossed extensor reflex will, the opposite muscle group of the damaged limb engages. Very good. Neuromuscular reflexes involve both reflex arcs and spinal nerve outlets, which we mentioned. Muscles function as both sense receptors and effectors. We have little nerve structures in each muscle that respond for themselves. The way they do that is often, by engaging the opposite muscle to prevent damage to the primary muscle. When an agonist muscle fires, an equal nerve impulse fires to release the antagonist muscle to an equal extent. We call that Sherrington's law. You'll sometimes see it. It's basically Newton's third law in a nutshell for people who are engaging. Very good. Reciprocal inhibition is something that we use as a stretching model. We'll actually resist the antagonist muscle's engagement to shut off an antagonist. Some of your massage teachers will show you that. When treating or injured or impaired muscles, the use of reciprocal inhibition can release damaged tissue to prevent further tearing or injury. As for nerves and the muscles, we have a couple of sensory nerves in the muscles. Right here we see traveling of specific nerve motion here. And we've got two specific structures, one called muscle spindles, the other called Golgi tendon organs. We're going to start with muscle spindles today. These are proprioceptors. They tell where the muscle is in time and space. And these are usually located inside the belly of a muscle. They sense lengthening or stretching due to connection to the endomysium and perimysium of the muscle. Muscle spindles are intimately connected with our connective tissue and know when our structures are moving. We can actually see there's an alpha nerve going straight to it, as well as a gamma nerve. The difference between alpha and gamma nerve are going to produce two different things. The alpha loop is going to innervate extrafusal fibers, the outside. Reflexes are going to be for the stretch reflex of the alpha. We also use this as the primary motor and sensory pathway. So when your muscle feels things or when you're telling your muscle to do things, it's the alpha nerve or the alpha loop that's doing it. Whereas you also have a gamma nerve going to these muscles. They innervate the intrafusal fibers, the deep layers of the muscle, and they regulate the sensitivity of this nerve structure. If your gamma loop becomes overtight and engaged, it leads to a different pathological condition. And to understand that, we're going to talk about, real quick, gamma gain. If the muscle spindle is tensed or the muscle is loaded, there's an increased sensitivity to that same muscle being rapidly lengthened or tensed from that position. Think of it as the muscle has become very sensitive and it's kind of holding itself in position. Some of you might know people who are constantly kind of gently holding onto themselves the whole time, or not so gently holding onto themselves. We call that gamma gain, where someone is constantly clenching the internal aspects of their muscles. It leads to increased sensitivity in a very particular condition. We will get to that condition shortly. But before we talk about the gamma gain condition, we have to talk about an alpha gain condition. We call those trigger points. Trigger points and tender points. We're going to talk about those. Some of you have already started taking Western 2, so you know a bit about this. But a trigger point is a hyperirritable area, locally sore. When you touch it, it spasms, and it can refer pain, tingling, and other autonomic phenomena. According to your Archer textbook, trigger points are caused by motor end plate dysfunction and calcium spill. Now, what does that mean? Motor end plate dysfunction means that the area of the motor end plate, when you send nerve signals across to it, when you send acetylcholine, will flood the area with calcium whenever that signal occurs, and then draw that calcium back out of transverse tubules. Some of you remember that from AMP1. Well, if that structure is damaged or if it's overly tired and the calcium's not flowing back, they've got a bunch of calcium ions floating around that area called calcium spill. The calcium spill is going to keep that area slightly engaged, slightly voltage oriented, which means that the muscle will be slightly turned on perpetually. And that leads to a hard little area where that muscle's extra tight and an inability of the muscle to function strongly. And we call that a trigger point. That is our best understanding of trigger points currently. Science may change tomorrow. Trigger points can be active, which means they're hurting right now, or they can be latent. They might have once hurt, they don't hurt anymore, but they can still affect the muscle and its contraction ability. Trigger point is abbreviated TRP. If we were in class, I would teach you about how to find trigger points. Since we cannot do that palpation-wise, try and track me down when I'm on campus, or definitely take palpation classes. Perhaps one of our associates at the school will teach you about how to find them properly. Trigger points can also be distinct. They can be primary, meaning they're causing other trigger points. They can be secondary, meaning they're being caused by a primary trigger point, or they can be satellite, which means that they're being caused by a trigger point that isn't even in the same muscle. If you have a trigger point in trapezius, you can have referral patterns into your temporalis, and have trigger points in temporalis that are satellite to a trigger point in trapezius, for example. We also have tender points. Those are abbreviated TEP. They feel very similar, although they can be even more painful, frankly, and they do not refer pain. They are just sensitive. Unlike the calcium spill of a trigger point, tender points are caused by high gamma gain signals, according to the Archer textbook. We associate tender points specifically, and they are considered a primary symptom for the condition fibromyalgia. Right. How do we as massage therapists tackle these? Well, trigger points are easily massaged. Trigger point therapy is a modality specific and useful for the treatment of that. Basically, any kind of percussion, vibration, myofascial release, engaged stretching can help to release trigger points. Tender points are a different story. Tender points respond best to neuromuscular therapy, the repositioning of the body, and specifically trying to shut off muscle spindle response. Jostling, gentle jostling becomes the way. This particular condition is being studied right now by the Touch Research Institute, and we're always looking for new information on how massage can help fibromyalgia and tender points. Because trigger points are not due to a neurological signal, repositioning is not necessary for treatment. Direct pressure is usually indicated with sensitivity. You don't want to vice down on them, you do want to let them go. Some textbooks do refer to them as neuropathies, and there's some debate about it. How does this change your work as therapists? Well, ultimately, you want to ask someone if they have fibromyalgia, if they're presenting with trigger points. You want to see if touch is agreeable to the individual or not. Always keep an open dialogue with your client when you're doing orthopedic or sports massages to make sure you're treating them properly. But I did mention there were two nerves. The other nerve that you will see is the Golgi tendon organs. These are found, you guessed it, in the tendons, and they do a similar function to the muscle spindle. They prevent overcontraction and overstretching. When you try to stretch a muscle and your muscle starts to freak out a little bit, you get that little shake in your muscle, that's the Golgi tendon organs firing to say, nope, you're trying to stretch me too far. Stop stretching me so far. It eventually shuts off when it realizes, oh, the muscle's not going to be damaged after all. That is an inverse stretch reflex. You're trying to stretch, it's trying to engage you so that you don't stretch. They're stimulated during muscle contraction, causing an active release response, leading to greater muscle relaxation. That's how we use it as massage therapists. Again, we see PNF and MET who will use these specific techniques in order to improve flexibility and allow for greater muscle release. In conclusion, knowing how nerves fire muscles and sense their positioning teaches us how they can lead to and often contribute to dysfunction of muscular tissue. Treating nerves is not always best done with compressive or firm massage, but often requires some understanding of how muscles and nerves interact, leading to intelligent touch decisions. Very good. Very good. That is our nutshell of our lecture today. Before I let you go, there is a homework assignment that is specific to this course of study. It is the homework assignment that it is due next week. The homework assignment is entitled Reciprocal Inquisition. Ha 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 ha, dad jokes abound. Reciprocal inquisition, I am bringing up that image right now, reciprocal inquisition, is found here. It's a simple little thing. You're going to look at the muscles here, and you're going to respond with one muscle, or two muscles, or three muscles, depending on the question, that is going to inhibit or be an antagonist to the muscle listed. I'll do the first one for you. One muscle to inhibit soleus. What function does soleus do? Soleus is a plantar flexor. So you're looking for one muscle that is specifically dorsiflexor. A good example of that might be tibialis anterior, for example. There are 8 groupings here. Make sure to read each one carefully. Make sure to consider what joints are being moved and what the muscles are actually opposing. Very good. That will be due for next week. That is your homework, which you will turn in. If you have any questions for me, please do reach out to me. Feel free to ask me any questions. Email me, text me. I do respond to texts fairly efficiently. This is your asynchronous lecture for week 9, and we have completed it. I hope that you all have a wonderful day, and be well. I will see you next time.